So thanks Manos and Manos for having me. I missed you last year, and thanks for inviting me. So Knut already did a lot of work, so there will be a little bit of redundancy, but I will try to make my point on acute dislocations and the keys to success. These are my disclosures. So factors to consider. I think if you treat AC joint instability, it's worth reading our consensus from the ESA, which is really comprehensive and very interesting to read. And it gives you a little bit of a guideline. So we need to consider, as Knut said, patient factors, what is considered acute and what is chronic. The classification, we know about the Rockwood classification for vertical instability and also about horizontal instability. And then we need to know the structures involved. We know CC ligaments, we're talking about the AC joint capsule, but we are not talking too much about the deltotrapezoidal fascia, which is a difficult word to pronounce, and concomitant injuries like the AC joint disc, slap, and rotator cuff lesions. So I will go more into detail with this. We know, like Knut said, the contact athlete hockey players for AHL, they need to sign that they won't have their AC joint repaired, because after 3 days, they will run into the band again and they will break everything. So hockey players are a contraindication. Overhead athlete, you need to know if it's the dominant, non-dominant arm. You need to know if what kind of grade, of course. But this is a patient factor that you need to consider. Heavy laborers, we know that heavy laborers with shoulder problems, whatever shoulder problem they have, it's difficult to get them back to their job. Compliance is also very important. Does the patient comply with your protocol or not? And heavy smoker, why did I put this in yellow? Because you can see a heavy smoker from being yellow. The beard is yellow, the fingers are yellow, then it's a heavy smoker. You don't even need to talk about pack years. So chronicity, in our consensus, we found that 3 weeks is considered still as acute. So below 3 weeks is acute, and above 3 weeks is considered subacute, and more than 6 weeks chronic. Of course, this is a consensus. There is very little literature out there, or if it's really the case, and if we are treating this the right way, but this is what we consented on. And I think it's a good guideline to somehow guide your treatments. We know the Rockwood classification. There have been some reports that we have a good inter-rater reliability. It's not perfect, as Knut said. 3B and 4 are really sometimes difficult, or 3 and 4 are difficult to distinguish. But I think it's not a bad classification we have. It was never, there was never a study on the reliability of this, but initially, but now we do have some evidence that it's not as bad. And then for horizontal instability, as Knut said, in the consensus, we did not say that you have to do Alexander views, but I do Alexander views. And you can see here, so the right shoulder is the intact one, and here you can see the AC joint separation with the horizontal override. So here you have just a little bit of a distance, and here you can see that there is a horizontal override of the clavicle. Basically, it's a acromion under the clavicle and not the clavicle over the acromion. And then radiographs, panoramic view, as Knut said, it's very good. Through AP, we don't need any additional imaging. However, I will go into this later. Clinical testing, scapular dyskinesia, I think Knut already made that point. And the horizontal override in crossbody is really, it's very important. It came up in the last few years since Isakos presented this. And I think this is really the key for success. And of course, pain. So structures involved. CC ligaments, we all know CC ligaments, usually they are ripped off, grade 3 and higher. So of course we need to repair these, or just make them have an option to anatomically heal. The AC joint capsule, so Felix Dirna, he showed in his biomechanical studies that it's really important. The anterior and the superior AC joint capsule is very important for horizontal instability and also for vertical instability. And also he showed later on that it's important, whatever you do, if you do A, B, C, D, E, address the AC joint. So this is really important. Then the fascia. It was never described by anatomists, and this is really interesting paper to read. They showed that they didn't find it. But why? Because it was formalin fixed specimen, and there you can't see it. You can only see it in fresh frozen or in our live patients, because then you can really account for the deltotrapezoidal fascia, which you can see here with the arrows. And it's a dynamic stabilizer. And we know that dynamic stabilizers are important because the AC joint is really difficult. On one hand, it's really stable. It should be stable. On the other hand, it should rotate 90 degrees when you flex your arm, and it should be stable in all other directions. And the anterior and lateral translations are really higher if you detach not only the AC ligaments, but also the DTF. Then, concomitant injuries. We only talk about the AC joint. However, we do have slab lesions, slab greater equal 2 more in Rockwood 5 injuries, rotator cuff tears, and chondral defects. And in patients at my age, over 35, we see an increase in concomitant lesions such as rotator cuff tears. I didn't find any study looking at the AC joint disc in the acute setting. However, in the chronic setting, a removal is advised. But I didn't find anything. Maybe I didn't look correctly, but I didn't find anything. So now, what do we do after all this introduction? The keys for success. Patient factors. I go conservative with contact athletes. Overhead athletes, it depends. Heavy laborer are rather conservative, malcompliance, and the yellow people as well. I go conservative, like Knut does, 1 to 3, and the 3 Bs, I'm more likely to go into surgery, but it really needs to be a shown AC joint override, a horizontal override in the Alexander views, and clinically it really needs to be clear. Then I go for surgery within 3 weeks. So if we go for operation in the higher grades, there are so many operations that were described. This shows us that none of the operations is perfect. However, we found, or the studies found, that the suture button is better, has a better function than hook plates. Hook plates, you know, they're considered as a chromium killer, and I do see a lot of problems with hook plates, and just putting K-wires is not a good option. Maybe K-wires in addition to CC reconstruction arthroscopically is a good way for horizontal instability. Then address the AC joint capsule. As I said, really important. Suture it. I do it with transosseous sutures because usually the AC capsule is stripped off the lateral clavicle, and then you can suture it back after you did the CC reconstruction. Then loss of reduction is not relevant. Last week in Paris I was asked, why do you operate on them if loss of reduction is not relevant? Of course, loss of reduction, we always see it, but it's not back, usually not back as it was before to a grade 5 or something. So, take me home. What you need to know, you need to know who's in front of you, like always. You need to know if it's 3 weeks or not, the Rockwood grade, do we have a horizontal override, and concomitant injuries. In patients over 35, I go for an MRI. Keys for successful surgery, as I said, I do an arthroscopic assisted, so the good thing is you know what's going on in the joint as well. Then you need to address vertical instability, horizontal instability by arthroscopic assisted CC reconstruction with buttons, and I over-reduce. I usually have the patient in the Trimano, so I over-reduce them, and I have the assistant pull them down, and they always lose, and then at the end they're nicely reduced after a few weeks. Of course, they have a little bit more pain. horizontal instability by repairing the AC joint capsule and the delta trapezoidal fascia. No need to address the AC joint disc. I did that initially, but now I'm not doing it anymore, and I don't see more problems and no graft augmentation. What are the keys for successful overall treatment, not just in the acute setting operatively, but overall treatment? Put them in a simple sling, let them move early. I tend not to move them as early as Knut does, but I let them move a scapular setting, do the scapular setting with the physiotherapy twice a week, but the rest is in the sling for 4 weeks. Then start full range of motion, weight bearing after 6 weeks, and then full return to overhead activities after 12 weeks, and full return to full weight bearing, and everything is after 3 to 4 months. And pain is also a criterion that is important to consider. So that's it. I would like to invite you to the Basel Elbow course, and if you have any questions, I'm here.
Thank you, Claudio. Are there any questions from the audience? Yes.
There is a question over there.
Pass the microphone there, please.
Hi, Claudio. It's me here, Hofer.
Yeah. Hi.
I wondered. I mean, we had Knut before, and my thought as well. And why is the 3 weeks if we know that the results will be the same if you do it early or you do it late? Why you cut it in 3 weeks? That's one question. The other one, you said that you do it arthroscopically. How do you repair the fascia arthroscopically? Give us some ideas.
So 3 weeks, I go for the 3 weeks because I think the CC ligaments, they're really under very much tension when you have an intact AC joint, more or less. And if it's ripped off after 3 weeks, I'm afraid that they will just peel back, and then even if you do a CC reconstruction, they won't find their way. And the hematoma, we know that the hematoma after 2 weeks is already organizing, and then after 3 weeks I can still reorganize the hematoma because I don't go between clavicle and the coracoid. I'd go below and above. So I personally think that there is still hematoma after 3 weeks that can organize itself, and the two stumps can work together.
You hope that gravity doesn't work in a stub stent.
Yeah, but that's my hope, and I think we discussed this a lot. It needs to have a biologic healing. Just the CT reconstruction with the tapes is not enough. Yeah.
I think.
I agree with that, and I think that we need to have some biology in any case. And I don't know what Knut is doing, but what I'm doing is I get the same results if I do it early or late. So I'm waiting for that in that case.
I absolutely agree with you, and I think that's a little bit coming up in the future, that the techniques where we use biology, is it ACCR, Masoka technique, hybrid techniques where you have a tendon, we are getting more and more reliable that these are the more reproducible techniques. The only thing about talking about these early things is when you try to go without a tendon. It's always the thing in Germany, we don't have allografts, we have to use a tendon either from the knee or somewhere. And if you go in very early, you might have a chance, or you have a chance to get it healing without biology. And the very interesting part about this 3 weeks thing is there is no study out there, no animal study, which gives us this time frame. There is a HSM paper from 96 where they looked what authors said what was their time frame.
Well, I remember, I'm old enough to remember that initially they said in the first 6 weeks, and then said the first 3 weeks, and then someone said in the first 2 days.
Yes.
And to be honest, there's no data whatsoever, and I don't believe that gravity doesn't work. And if you don't put biology there, I don't think that you'll get something. The problem is if you use anything that is not biological, and you limit, for some reason, the obligatory rotation movement of the clavicle, you'll get erosion of the clavicle, cheese cutting, and we've seen that with different implants that don't have biology.
But the very nice part is we've also seen it with the tendons in the ACCR technique. So the Mazzoca technique without non-biology, only tendon has the same tunnel widening as we have it with the synthetic graft.
Okay, one more question.
And the second thing, I think you asked the second question, arthroscopic assisted, it's arthroscopic assisted. I still open, I do a coup de sabre, and then I look at the fascia, and then I suture it, always.
Because I think the major key in the success of this operation is to repair the fascia.
Yes.
And I did arthroscopically many years ago, and I went back to do it open because of that. Because you can't really repair the fascia arthroscopically.
Yeah.
I just want to make a point related to the difference between type 3 and type 4, because I trained with Dr. Rockwood and I have been in touch with him for many years, and there are two completely different animals. You know, the type 4 is a fixed displacement of the clavicle, a posterior displacement. So it's completely different to type 3. Generally, the clavicle goes through the trapezius. So it's a matter of just examine the patient from up, and you will see that a type 4 is a very characteristic dislocation, and it's completely different to the type 3, even to the type 3B.
Yeah, I don't completely agree, because I think maybe in type 4 it's fixed, but
Yes.
still in type 3B the fascia does give some room for the clavicle to move posteriorly.
Yes,
so
that's
I think maybe the 3B is or the 4 is like a meniscus that's subluxated, you know, like a bucket handle tear, and that does not go back. But the 3B is the one that goes back.
Yes.
Okay,
yes.
time is running, so we
Okay,
have to...
it's just
Is
a
there
dynamic.
one more question, I think? Last question.
Congratulations on both speakers, very nice presentations. Just one question, maybe you can choose who wants to answer. Does any of you have experience in, because we use the Rockwood classification of saying this is a serious injury and not serious, do you have any experience of history? Maybe a 3 can become a 2, 2 can become a 5, 3 can become a 5, a 3B can become a 3A. Do you have any experience, or are we just treating one single X-ray?
Yeah, to be honest, I don't look at this directly. If it becomes a 3B becomes a 3A, I look if the patient's doing well. But maybe you know something.
That's exactly what we are trying to figure out. The classification, the X-ray, is only one part of the puzzle. And you're right with the Rockwood original, and I think what we try to find with this 3B is this dynamical impingement into the trapezius or the acromion, and this is the painful thing. Very seldomly they are really hooked into the trapezius. And yes, I've seen guys, very strong guys, who we initially X-rayed with a CC distance of 50%, type 3, and we did an X-ray 6 weeks later, and he had a type 5. He was a police guy. I think in the first, and that's very important, in these first painful weeks, and that's also a reason why I don't do stress X-rays with weight. They scrub the clavicles and they keep their shoulders up with the muscle. And if you get them in a relaxed state later on, where they don't have so much pain anymore, they get let more loose. And in these situations, you might pick up a dynamic that it gets more instability grade.
But that's more progression. But I think Klaus wanted to say that it's getting less.
Klaus wanted to say us that don't look at the X-ray.
Okay, let's move on to the next